So today's topic of discussion will be oral mucositis. It is one of the important area to be discussed and described when it comes to oncology patient or the cancer patient, especially in the treatment adherence area. That is the major thing in chemotherapy. The patient may will not adhere with the treatment regimens. We will, without delay, we will move further towards the oral mucositis. So oral mucositis, what it is actually, it is an inflammatory and ulcerative condition of the oral mucosa. So what happens, it is an inflammatory or an ulcerative condition of oral mucosa occurring as the toxic effect of cancer chemotherapy. It can be chemotherapy, it can be radiotherapy, and it can be or the hematopoietic stem cell transplantation. So when it comes to these three area, you have to understand is like chemotherapy, there are some specific drug which can further contribute more into the oral mucositis. Radiotherapy, which especially when it comes to the head and neck cancer, when the head and neck radiotherapy, the patient can develop many complications other like pharyngitis, esophagitis, and more commonly oral mucositis is also seen in these patients, and the hematopoietic stem cell transplantation. So this is an area where the patient is receiving high dose chemotherapy as part of the conditioning regimen. So that also will be resulting in the oral mucositis. So what happens, it results from the damage to rapidly dividing basal epithelial cells. So this is the point which you have to understand. The dividing basal epithelial cells is the area which is getting affected. Yeah, so what happens here, the when you see the skin layer, it is divided into epithelium followed by the basement membrane, the connective tissue, and the submucosa. So how it is divided? So when you see the skin layer, it is divided into the first it is the epithelial layer. Epithelial layer is followed by the basement membrane. So the basement membrane is followed by, again it is followed by the connective tissue, and then followed by the submucosal layer. So this is how the skin layer is this is how the skin layer is formed. So in this, when you see the epithelial layer is further divided into the first or the topmost layer is the stratum basale layers, the stratum basale. So this layer is the one which is getting affected in the oral mucositis. So when you see the oral mucositis, you may get confused with other ulcers. Okay, so you might have heard about the aphthous ulcers or the canker sores. So how can you differentiate exactly the oral mucositis? Is the oral mucositis is little more acute and it little more widespread, and it's the important thing is it is the common part of chemotherapy and the radiation therapy. It basically appear as the red or white sores, that is the aphthous ulcers or the canker sores, that can be a part of trauma, diet, stress. Okay, and usually it is isolated. So this is one of the important thing when it comes to the mouth ulcers. We usually get mouth ulcers, but there is a big difference between the oral mucositis as well as the other mouth ulcers. So what is the major causes or what is etiological factors? So whatever we have discussed, some of the cytotoxic, most of the chemotherapy, some has an important role. So the anti-metabolites, the alkylating agents, like we will see to the examples of that, and the radiotherapy to the head and neck region, combined chemoradiation, bone marrow or stem cell transplantation, neutropenia. When the patient is having already immune suppression, the whole patients, when the patient is the whole immunity of the patient has been lost, already the patient has been undergone schedules of chemotherapy. So in that cases, the patient will be further at the risk of having oral mucositis. There can be other conditions like if you take examples of the patient is already having poor dental hygiene, or the patient is having malnutrition, and maybe they are having alcohol, smoking use, this can contribute again towards the oral mucositis. Reduce salivary flow, we know what is the importance of saliva. It has a very good antimicrobial action. So this also will be if the patient has reduced salivary flow, maybe some sort of genetic polymorphism affecting the inflammatory pathways, so that ultimately resulting in the inflammatory cytokine production. So these also will be resulting in the what this can contribute again towards the oral mucositis. So what is the pathophysiology of oral mucositis? So when you see, there is some phases. So it has been actually given by Dr. Stephen T. Sonis. He has written a very good book on oral mucositis. So there is something called the 5-phase biological model. So as you can see in this image, so there is a phase, or the starting phase, or the initiation phase. So in the initiation phase, what happens? The chemo or the radiation, whatever, let it be the contributing factors, it literally causes a direct DNA damage to the basal epithelial cells. So when a DNA damage happens, cells need more energy to repair, isn't it? Cells need more energy to repair. So the mitochondria will be overactive here. So this overactive mitochondria will be leaking the electrons, leading to formation of the, or the generation of the reactive oxygen species. Ultimately, the main important thing that you have to remember in this is the reactive oxygen species. So when this happens, what happens? The damage is occurring not only to the epithelium but also to the other cells like endothelial cells, the fibroblast, the extracellular matrix is also getting affected. So the ROS has many functions. One of the important function of the ROS is the message generation. So the ROS will be activating the transcription factors like nuclear factor kappa. So this is one of the transcription factors. This is a master transcription factor. So that will be what happen? This will be initiating the pro-inflammatory microenvironment. So these cytokines will initiate an environment where an inflammation can occur. So this also will be releasing the tumor necrosis factor alpha, interleukins especially 6 and 1 beta. So these things will be released. Okay. So once this is released, so again the signal amplification, this will be resulting, like the cytokines is already, or the pro-inflammatory microenvironment has been already created with the help of reactive oxygen species. So now again there should be repetition or an amplification. Amplification literally means the repetition of this process has to be occur. So again, when because of the pro-inflammation or the pro-inflammatory microenvironment, when the cytokines are produced, again the tissues is getting damaged, again ROS is produced, then again that will be resulting in again inflammatory environment. So this goes as a cycle, or this goes as a repetition, that is termed as the signal amplification, and further it will be resulting in the ulcerative phase. So ulcerative phase, you can see clinically visible ulcers. So these ulcers can be covered with a fibrous pseudomembrane. Otherwise it can be painful, and this is the phase where the patient understand that the patient has got an ulcer, where there will be pain, and this can further result in the bacteria and fungi will penetrate through the ulcer base, and they may have increased risk of infection, bacteremia, sepsis, especially when it comes to neutropenic patients. And all this comes, and the patient will not be will stop the chemo. This is the stage where the patient will be losing the treatment adherence, everything. And when it comes to the next phase, there is a healing phase, the cellular regeneration, the tissue repair phase, isn't it? So what happens here, the occur after the reduction, or the we are just stopping the cytotoxic therapy here. So the epithelial proliferation and the differentiation and migration happens here, because the repeated cycles are not happening here. So what happens, the cellular regeneration is happening. But if the cycles are again repeating, again the patient is getting the cytotoxic therapy, and the cells are not getting a time to heal, again it can continue, the cycle can continue, further deteriorating the oral mucositis. So this is what the same thing what we have discussed, the 5 biological phase of mucositis. Okay, so when it comes to risk factors, the same thing what we have discussed, like malnutrition, xerostomia, pre-existing oral diseases, tobacco, alcohol, poor oral hygiene, and the chemo and the radiation. So this is some of the chemotherapeutic agents that can result in the oral mucositis, like as I already mentioned, some of the common antimetabolites and the alkylating agents. So as I remember a patient I have seen last day, it was he was a child, a 5-year-old child. So he was receiving melphalan. Patient was receiving busulfan. So busulfan, the patient was undergoing hematopoietic stem cell transplantation. So of that patient was getting a busulfan, so as a part of conditioning therapy. So the patient or the child was instructed to have ice or ice cubes or ice cream while the infusion is ongoing. So why this is done? When an ice cream or ice cube is done, of course the vasoconstriction happens, the blood flow to the specific area is reduced. So this high dose chemotherapy, or maybe the chemotherapy which has a greater side effect, that is like oral mucositis, the amount of drug that is going to a specific area is reduced, like to the oral mucosa or the oral cavity, the drug that is received is comparatively less when they have, or when they suck the ice cubes or the ice creams. So that is that is called actually cryotherapy. So this is one of the important treatment method that is taken. Okay, so coming to the clinical manifestations, we know it is like very painful erythema and edema of the oral mucosa, followed by the pain and burning sensation. So the pain and burning sensation, so the patient will be having severe pain, and ulcerations and pseudo membrane formation will be there. Patient will be having difficulty in chewing, swallowing and speaking, like that is termed as the dysphagia, difficulty in swallowing, and odonophagia, painful swallowing, altered taste sensation. Patient again can go into severe, already the patient will be having cancer cachexia, along with that patient can deteriorate further, along with the malnutrition, and patient can go into severe weight loss and other associated health issues, increased risk of local and systemic infection, reduced oral intake leading to the malnutrition. So the grading is usually, when we speak, we know that the WHO oral toxicity scale is one of the scale that is used. So the grade 1 is just soreness with or without erythema. Grade 2, you can see the patient is having erythema but they can eat the solids, whereas grade 3, ulcers will be present and the patient can eat liquid diet only, not solids. And in grade 4, the patient cannot tolerate any sort of oral food. So this is one of the oral assessment guide, or the OAG. So here you can see there are some items like voice, swallow, lips, tongue, saliva, mucous membrane, gingiva, teeth or dentures. These 8 components is assessed. So based on the there is some criteria where you will be seeing the oral assessment, you will be checking. So 8 to 10 values gives the normal, 11 to 14 will be moderate, and early mucositis can be we can assess, and 15 to 24 there will be severe or advanced form of mucositis. So each of the item will be having some different components under that. So the complication, the patient, if it goes on, they can result in secondary bacterial or fungal infection, and and sepsis in the neutropenic patients, treatment interruptions and dose reduction. As I already mentioned, the treatment adherence might be lost, weight lost. Weight loss is very important thing. Patient may not eat and drink any sort of food, and some of the patient, like in radiotherapy, seeing this before receiving the therapy itself, the patient will be having RT. The RT will be inserted. So that proper malnutrition, and the reasons are like esophagitis, pharyngitis, those are some another reasons, but still patient will be on ET and decreased quality of life, especially for the caregivers as well as the patient. It's very difficult to manage. Coming to the medical management, we know some of the topic analgesics and anesthetic mouth rinses, like especially when it comes to the oral mucositis, pain is also very important thing to manage. So systemic analgesis as well as the local anesthetics, like the mouth paste, that is also very important. So there are many sort of pharmacology advanced therapies. So one of the thing, some of the you can see here, like this is not commonly preferred and not commonly used, like magic mouthwash. This is a combination where you have antimicrobial, antifungals, anesthetic agents. So all those things will be but it's not given in an exact formulation, and there is many controversies behind that. So lidocaine, like numbing agents, the antihistamines, antacids, antifungals, especially steroids, everything together will be combined. and benzidamine mouthwash. This and the site that is gel containing choline salicyclate and benzalkonium chloride solution. This is also commonly preferred one. Lidocaine viscous. So lidocaine hydrochloride we know act as a numbing agent, or you can it act as a analgesics. So these are the commonly preferred medicines. So when it comes to nursing management, so regular oral assessment, as we have seen one guide, OAG guide, and many other standardized tools are there. So regular assessments, meticulous oral hygiene, especially soft toothbrush to be used, non-irritating mouth rinses. When it comes to hospital basis, we'll be using saline, or when it comes to home base, very it's not that lukewarm water with a pinch of salt, very small amount of salt can be used, and but it should not be high in an amount which will be irritating. That should be kept in understanding. And avoid alcohol based mouthwash. There are a number of mouthwashes we use for the oral care daily, but that is not the one we have to use. The alcohol based mouthwashes should be avoided. Pain assessment and timely analgesic administration, adequate hydration, soft bland diet. If the patient is having NG, the appropriate diet should be given, and if the patient is taking orally, soft bland diet, especially the spicy food, everything should be avoided. Signs of infection should be checked, especially the patient will be receiving sort of antifungals and antimicrobial therapies, so this should be checked side by side, and provide patient education as well as caregiver education. So this is one of the core elements of oral care protocol for patients, has been taken from the cancer nursing textbook. So brush all tooth surfaces for at least 90 seconds. So we cannot deny telling like oral mucositis, we cannot deny the oral health. So it's very important to take 90 seconds using a soft toothbrush twice daily. Allow the toothbrush to air dry before storing. Replace it on regular basis. So whatever we are using into the mouth should be taken care also. That should be infection, and it should be free from any sort of infection. Floss at least once daily or as advised by clinician. Rinse the mouth 4 times daily. Avoid tobacco, alcohol, irritating foods like spicy foods, and use water based moisturizers to protect the lips also. So lips is very important. Ulcers can present there also, isn't it? Yeah. So maintain adequate hydration. So these are the important strategies. Some patients will be receiving the pre-treatment dental evaluation before radiotherapy and all, and oral hygiene protocol, whatever we have discussed, cryotherapy as I mentioned, and the patient education, oral care practices. So these are the important aspect, preventive strategy when it comes to the oral mucositis. So this is all about oral mucositis. It is a very vast topic. You can read more on that. It's a very gist I have said what is an oral mucositis for the understanding. Yeah. Thank you.